Imagine surviving breast cancer. I mean, you go through the absolute gauntlet of diagnosis, surgery, maybe chemotherapy, and you finally get on a life-saving maintenance medication.
Yeah, it's an incredibly exhausting journey. And you expect some side effects, of course.
Right, you expect side effects, but nobody really warns you that while this drug is, keeping the cancer at bay, it might be fundamentally dissolving the structural scaffolding of your pelvic floor.
They just don't tell you. And to make matters even more confusing, you might be taking a medication that causes your tissue to look perfectly healthy, like overly moisturized even.
Exactly, while the structural joists underneath are literally collapsing.
It is the absolute definition of a physiological optical illusion. What you see on the surface simply does not reflect the structural reality beneath it.
Wow.
And for a long time, the medical community just, handed these women a tube of lubricant and told them it was a standard part of survivorship.
Which is incredibly dismissive when you realize the sheer mechanical failure happening at a cellular level. So, welcome to this deep dive. Today, we have a highly specific and frankly crucial mission.
We really do.
We are answering a question that affects millions of survivors but is rarely unpacked beyond surface-level symptoms. Can life-saving breast cancer treatments, specifically hormone therapies like tamoxifen or aromatase inhibitors, actually cause or worsen vaginal laxity, pelvic organ prolapse, and, well, a fundamental loss of elasticity?
We are talking about deep tissue biology today. The distinction between surface dryness and deep structural failure is everything.
Yeah, it's a massive difference.
We are going to look at what these drugs do to the cellular scaffolding of the pelvis, why two different breast cancer drugs can act in completely contradictory ways down there, and what the latest science says about safely managing these changes.
To get to the bottom of this, we were pulling from a massive, and I mean massive, stack of sources today. We've got clinical guidelines from the British Menopause Society, deep dive physiological rat models, and quality of life observational studies that really highlight the daily realities for patients.
Not to mention the most recent clinical trial data up to 2025.
Right. Okay, let's unpack this. Before we can understand how these drugs change the pelvic floor, we really need to understand how it is built in the first place.
Yeah, establishing that baseline is key.
I like to think of estrogen as the architect and the maintenance crew of a building's structural scaffolding. Like when estrogen is present, the crew is actively working, patching holes, and keeping the steel beams flexible but strong.
I love that analogy. The steel beams in your building are what we call the extracellular matrix, or ECM. This matrix is a complex web primarily made up of type I and type 3 collagen, along with elastic fibers.
So that's the literal physical structure.
Exactly. It is the deep connective tissue that literally holds everything together. Your bladder, your uterus, your rectum. It keeps them suspended and in place. And estrogen is the master regulator of this entire architectural system.
Let's break down the mechanics of that maintenance crew, though. How does estrogen actually tell the body to keep the scaffolding strong?
So estrogen does a few critical things simultaneously. First, it directly promotes the synthesis of new collagen and elastin by interacting with specific receptors on your cells.
Right, the ER-alpha and ER-beta receptors, right?
Spot on, estrogen receptor alpha and estrogen receptor beta. But its second job might be even more important. When estrogen binds to these receptors, it actively inhibits a group of enzymes called matrix metalloproteinases, or MMPs.
MMPs. So are those essentially the demolition crew? Like their whole job is to tear down the building?
They are the demolition crew, yeah. But let's not villainize them completely. In a healthy, functioning tissue cycle, you need a little bit of demolition. You have to clear out old, damaged tissue so that fibroblasts can lay down fresh collagen.
Oh, I see. So it's a constant cycle of tear down and rebuild.
Precisely. But estrogen keeps those MMPs on a very tight leash. When estrogen levels drop, which happens naturally during menopause, that leash just snaps. Without estrogen to suppress them, the MMP demolition enzymes essentially run wild.
Wow, so they're just destroying everything.
Yeah, they start breaking down the tissue much faster than your body can repair it. At the same time, collagen cross-linking drops, meaning the individual fibers stop binding together as strongly.
So the tissue isn't just getting thin, the actual mechanical strength of the biological glue is failing.
If we connect this to the bigger picture, this unchecked cellular demolition leads to a profound thinning of the vaginal wall. It causes a narrowing of the introitus, which is a vaginal opening, and a massive loss of elasticity.
Which has to be incredibly uncomfortable.
It is. This cascade of structural failure is a primary contributor to pelvic organ prolapse, or POP, where the pelvic organs literally drop from their normal positions. It's also the driving force behind the broader genitourinary syndrome of menopause, known as GSM.
Okay, so that paints a clear picture of natural menopause, where estrogen gradually declines over a few years. But I want to pivot to our first class of breast cancer drugs, aromatase inhibitors.
Right, the AIs.
Drugs like anastrozole or letrozole. They're used to treat hormone receptor-positive breast cancer by shutting down the body's estrogen production. But I have a fundamental question here. In postmenopausal women, the ovaries have already shut down, right?
Yes, the primary estrogen factories are closed.
So if they are already in menopause, why does an aromatase inhibitor make the pelvic floor collapse so aggressively?
Because the ovaries aren't the only factory in town. Even after menopause, the body still manufactures androgens. An enzyme called aromatase takes those androgens and converts them into estrogen in your peripheral tissues, like your fat cells, your muscle, and breast tissue.
Oh, wow. I didn't realize the body was still making it elsewhere.
It does, and that peripheral estrogen is enough to provide at least some baseline maintenance for the pelvic floor. Aromatase inhibitors block that conversion entirely. They don't just reduce estrogen, they obliterate it.
Meaning the pelvic floor is suddenly and entirely starved of its architect and its maintenance crew overnight.
Exactly. The resulting drop is a very profound, incredibly accelerated version of genitourinary syndrome of menopause. The vaginal and urethral epithelium thins significantly.
It just strips it all away.
Yeah. Going back to that extracellular matrix, the complete lack of aromatase activity specifically halts collagen cross-linking. The tissue essentially stops reinforcing itself entirely.
The quality of life observational studies really drive this home. It's not just a surface-level moisture problem that you can fix with an over-the-counter cream. Women on these AIs describe a feeling of absolute structural weakness,
It's debilitating for many.
severe dryness, and a total loss of elasticity that makes intimacy incredibly painful, sometimes impossible.
The systemic impact of that estrogen starvation is staggering. To give you an idea of just how aggressively AIs degrade connective tissue across the entire body, look at the joint data.
The joint data, like knees and elbows.
Yeah. Almost half of the women taking aromatase inhibitors experience severe musculoskeletal pain, known as arthralgia. Their knees ache, their hands stiffen up. The connective tissue in their joints is degenerating from the estrogen deprivation.
Oh my gosh. If a drug is aggressively breaking down the thick, heavy connective tissue in your knees, you can only imagine what it's doing to the delicate, highly estrogen-dependent scaffolding of the pelvic floor.
It is a systemic structural crisis.
Which brings us to the second major drug in our stack, tamoxifen. And this is where the story gets wildly counterintuitive. AIs are pretty straightforward. They block all estrogen, the tissue breaks down.
Simple, brutal math.
Right. But tamoxifen is a selective estrogen receptor modulator, or a SERM. From my understanding of the sources, a SERM acts as an anti-estrogen in the breast, which starves the cancer. But it can act as an estrogen in other parts of the body.
That's the selective part, yes.
So if tamoxifen acts like estrogen in the vagina, shouldn't that mean it protects against vaginal laxity and dryness? I feel like I'm missing something here.
You've hit on one of the most frustrating paradoxes in survivorship oncology. Tamoxifen creates a bizarre, contradictory environment in the female genital tract. Because it has partial estrogen-like effects, the clinical data confirms that in postmenopausal women, tamoxifen can actually thicken the vaginal epithelium.
Okay, so it does help the tissue then.
On the surface, yes, it increases glycogen production, and it triggers a process called mucification, producing a clear, water-like discharge that isn't related to an infection.
Let me bring back my building analogy. Tamoxifen sounds like a house with a brand new coat of paint on the outside, but rotting structural beams on the inside. Because on the surface, a woman on tamoxifen might not feel that severe sandpaper dryness that a woman on an AI feels. The surface looks moisturized.
The surface is incredibly deceiving. There is a fascinating study by Kim and colleagues that dug into the deep tissue effects of tamoxifen on the vaginal physiology of rats. The methodology was intense.
What did they do?
They used subcutaneous osmotic pumps to constantly deliver tamoxifen, and then they physically stimulated the pelvic nerve to measure real-time physiological responses. They confirmed that the vaginal epithelium was highly mucified, producing lots of carbohydrate-rich compounds like mucin.
So the body was definitely producing lubrication.
Copious amounts of it. But the researchers measured deeper parameters and found a massive drop in vaginal blood flow. Furthermore, tamoxifen drastically decreased the activity of an enzyme called arginase.
Arginase, what does that do?
Arginase is an absolute requirement for regulating cell growth and maintaining the local blood vessels. The researchers hypothesized that this lower arginase activity is a silent, early physiological change that fundamentally compromises the tissue.
Wow, so the blood supply is just quietly choking off.
Yes. Over time, despite all that surface mucus, the underlying tissue experiences poor perfusion, meaning terrible blood supply, which eventually forces the tissue into atrophy.
Here's where it gets really interesting, because when you take that rat model and map it onto actual human clinical trials regarding pelvic organ prolapse, the data is incredibly conflicting. Let's look at two specific human studies from our stack, the Naumann and Vardy studies. Right. First, we have the Naumann study. They tracked 143 women on tamoxifen. They found that tamoxifen had virtually no effect on pelvic organ prolapse itself. However, it caused a massive 42% increase in stress urinary incontinence.
Which means the structural support for the urethra was failing, causing leakage, even if the larger pelvic organs remained in place.
But then you contrast that with the Vardy study. This was a double-blind randomized trial, the gold standard of clinical research. They found that tamoxifen actually worsened pelvic organ prolapse in a staggering 60% of patients.
It's a shocking number.
Let's just pause on that. 60%. Compare that to only 18% of patients whose prolapse worsened while taking a placebo. Think about what that means for a patient. You've survived cancer, you are dealing with the daily fatigue of survivorship, and now a drug that is supposed to save you is structurally compromising your body in a way nobody warned you about.
It's deeply unfair.
How can a drug that acts like estrogen on the surface cause the deep tissue to fail so catastrophically in so many women?
We call this the tissue selectivity paradox. The net biological effect of a SERM like tamoxifen is heavily dependent on the local expression ratios of those estrogen receptors we talked about earlier, ER-alpha and ER-beta.
So it behaves differently depending on the specific cells it hits.
Exactly. It seems that in the deep pelvic floor fibroblasts, the specific cells responsible for building the collagen scaffolding tamoxifen acts more like an antagonist. It fails to inhibit those destructive MMP enzymes.
So the demolition crew is still running wild in the basement, actively destroying the joists.
Even while the painters are touching up the siding on the ground floor, yes.
That is wild.
The researchers publishing in the Frontiers Journal highlighted this exact mechanism. They noted that the connective tissue of patients with pelvic organ prolapse naturally shows an altered, elevated ratio of ER-alpha to ER-beta.
So they're already vulnerable.
Right. It is highly likely that tamoxifen further alters this delicate receptor balance or simply blocks the downstream pathways required to synthesize collagen. It actively undermines the stability of the connective tissue, worsening laxity and prolapse, completely independently of the surface-level lubrication it causes.
Okay, this is a heavy reality for anyone listening who is currently on these medications. Knowing that both aromatase inhibitors and tamoxifen severely alter the pelvic floor's structural integrity, either by starving it or confusing it, how can a listener safely manage this?
It's the most important question.
How do you rebuild that scaffolding without accidentally fueling a hormone receptor-positive breast cancer?
This is the million-dollar question in survivorship care, and thankfully the answers are getting much better. The absolute first-line defenses are always non-hormonal. This means using high-quality, pH-balanced, non-hormonal moisturizers.
And not just for intimacy, right?
No, not just lubricants for intimacy, but daily moisturizers to manage the surface friction. It also requires mechanical stimulation. Pelvic floor physical therapy, Kegels, and the use of vaginal dilators are crucial.
Let's talk about the science of physical therapy for a second, because it's not just about, like, working out a muscle. Mechanical stress actually changes the cellular behavior, right?
It's a biological principle called mechanotransduction. When you use a dilator or perform pelvic floor exercises, you are physically stretching the fibroblasts.
You're literally pulling on the cells.
Yes, and that mechanical stretching sends a signal through the cell's cytoskeleton straight into the nucleus, basically waking the cell up and telling the genes to lay down more collagen. You are using physical force to trigger structural repair.
That's incredible.
But, as many patients know, sometimes non-hormonal options and physical therapy simply aren't enough to stop the tissue degradation. That introduces the highly controversial topic of topical vaginal estrogen.
Which sounds absolutely terrifying if you've just survived a cancer that literally feeds on estrogen.
It is a massive psychological hurdle for patients. But the medical consensus is shifting dramatically based on a deeper understanding of how these drugs work. For tamoxifen users, prescribing low-dose topical estrogen is generally considered quite safe.
Really? Why is that?
Well, tamoxifen works by actively locking onto the estrogen receptors in the breast tissue and blocking them. So even if a tiny microscopic amount of the vaginal estrogen enters the systemic bloodstream, the breast receptors are already shielded by the tamoxifen.
Oh, that makes total sense. But for AI users, it's a completely different risk profile.
The mechanism makes it much trickier. Aromatase inhibitors don't block the receptors, they just stop the body from producing the hormone. The breast tissue receptors are sitting there completely unguarded, hungry for any estrogen that might float by.
So introducing any estrogen is a huge red flag.
Historically, oncologists strictly forbade vaginal estrogen for AI users because of the fear that even minor systemic absorption from a vaginal cream could trigger a cancer recurrence.
But our stack of sources includes some very recent, very optimistic data from 2025. The science is shifting on this, isn't it?
What's fascinating here is the sheer scale and definitive nature of the new evidence. We are looking at groundbreaking data presented at ASCO in 2025, specifically the Best et al. Study and the Mitchell et al. Study.
Those are huge studies, right?
Massive. We are talking about reviews encompassing tens of thousands, and in some metrics over 100,000 breast cancer survivors. This large-scale data strongly, consistently suggests that the use of low-dose vaginal estrogen does not increase breast cancer recurrence, and it does not increase mortality.
I want to make sure I'm hearing this right. Even for patients on aromatase inhibitors, the ones with the unguarded receptors.
Even for patients on aromatase inhibitors. And even for those with highly hormone receptor-positive breast cancers, the key is the dosage and the delivery method.
So it's about keeping it hyper-local.
Exactly. The systemic absorption from these ultra-low-dose topical treatments, like a localized estriol cream or a vaginal ring, is so minimal that it doesn't seem to wake up dormant cancer cells. The estrogen stays localized to the pelvic tissue.
So it fixes the local problem without triggering the systemic one.
Right. It absorbs into the vaginal wall, suppresses those MMP demolition enzymes, and allows the fibroblasts to rebuild the collagen scaffolding. This data is overturning decades of medical hesitation and offering massive, life-changing relief for patients suffering from genitourinary syndrome of menopause.
That is incredible news. It validates the pain these women have been in and offers a genuinely effective, scientifically backed solution. But I imagine some women, or perhaps their particular oncology teams, might still be hesitant to introduce any hormone whatsoever, regardless of the reassuring data.
And that's completely valid. It's a personal risk tolerance issue.
Are there alternative clinical therapies that actually rebuild the tissue without relying on estrogen?
The field of tissue engineering and localized therapy is stepping in to fill this exact gap. One of the most promising alternatives right now is fractional CO2 laser therapy.
Okay, I have to push back a little here. A laser. Inside the vagina. For a tissue that is already thinning and vulnerable, that sounds incredibly intense, maybe even damaging.
I know, it sounds medieval. But the cellular mechanism is actually elegant. The laser uses thermal energy heat to create microscopic, highly controlled injuries in the tissue matrix.
Controlled injuries, like microneedling for the face.
Very similar concept. This heat produces localized edema, which is basically a controlled swelling. That swelling triggers the body's natural wound healing cascade. It essentially shocks those sluggish fibroblasts back into action, stimulating them to create brand new collagen without needing an estrogen signal.
Wow.
The medical term for this is neocollagenesis.
So you are basically tricking the tissue into repairing itself by mimicking an injury.
Furthermore, the heat promotes neovascularization, meaning your body forms entirely new blood vessels in the area, which dramatically improves local blood flow.
Reversing that atrophy we saw in the rat study.
Exactly. Over a series of treatments, the stratified squamous epithelium, the outer layer of the vaginal wall, thickens, glycogen levels naturally increase, and the deep connective tissue regains much of its elasticity and structural integrity, all without introducing a single exogenous hormone.
That is remarkable. We've covered a tremendous amount of ground today, so let's quickly recap the journey. We started by looking at estrogen as the vital architect of the pelvic floor, keeping the destructive enzymes at bay and the collagen cross-links strong.
The master builder.
Then we saw how aromatase inhibitors essentially starve the entire body of that hormone, dissolving the structural glue and causing severe, painful laxity and systemic joint issues.
Right, the AIs just turn the factory off.
Tamoxifen, meanwhile, acts as a confusing double agent. It might thicken the surface mucus, but deep down it restricts blood flow and alters receptor ratios, which clinical trials show can actually worsen pelvic organ prolapse for a majority of users.
The physiological optical illusion.
Yet, despite these brutal side effects, the medical community is finally finding increasingly safe ways to rebuild that tissue. From using mechanotransduction with physical therapy to neocollagenesis with CO2 lasers, and now relying on massive 2025 studies confirming the safety of low-dose vaginal estrogen.
The shift in survivorship care over the last few years has been profound. We are finally moving past just telling women to deal with it and actually addressing the deep structural reality of what these life-saving drugs do to their bodies.
It's about time. And all of this deep science leaves me with a final thought to ponder. Throughout our stack of sources today, there's this underlying theme of tissue engineering. We now know the pelvic floor relies heavily on specific mechanical stress and a precise balance of estrogen receptors.
It's a highly tuned mechanical system.
If we understand the exact molecular pathways so well, like how inhibiting MMPs or altering arginase activity completely changes the tissue architecture, could future treatments for vaginal laxity and prolapse bypass traditional drugs entirely?
That's the frontier we're looking at.
Could we eventually see bioengineered vaginal scaffolds, perhaps seeded with localized non-hormonal modulators, that trick the body into rebuilding its own elasticity without ever introducing a single hormone to the rest of the system? Given the leaps we've seen just up to 2025, we might be closer to that reality than we think. Thank you for joining us on this deep dive. Remember to stay curious, keep asking the hard questions about your own body, and as always, discuss any changes to your treatment or symptom management directly with your oncology team. Until next time, keep examining the foundations.